Hello friends, this is a case of robotic bilateral transabdominal preperitoneal hernia repair. So, we will start the surgery for the right side of the indirect inguinal hernia with the robot, and it is the Da Vinci robot which it is used here. We can see this is the left hand has a atraumatic grasper and right hand has a hook, and now the preperitoneal space is being created. So, grasper will give the inferomedial traction and slowly peritoneum is incised from the anterior superior iliac spine up to medial umbilical ligament. And as we can see, areolar tissue plane has been achieved and slowly preperitoneal space is being prepared. We can see above is the inferior epigastric vessel, and now this is the medial dissection, that is medial to the inferior epigastric vessel. So, this is the separation of the peritoneum which is carried towards the triangle of pain in the lateral dissection. So, it is a combination of electrosurgical as well as blunt dissection, and care should be taken that inferior epigastric should not be injured. Now, again this is medial dissection and we will reach up to the Cooper ligament. Laterally you can see the arc of transversus abdominis is visible. So, we can see here triangle of doom is visible, vas and spermatic vessel. And further lateral dissection is progressed. Here is the sac, and the boundary of medial boundary of the lateral dissection will be a spermatic vessel. This is the inferior epigastric vessel. Now, medial to the inferior epigastric vessel, we can see here further medial dissection is being carried out, and idea is to reach up to the Cooper's ligament, that is pectineal ligament, and to just little bit separate the bladder medially to enter into the space of radius. So, we can see there pearly white color Cooper ligament was visible, and now the sac dissection is started. Assistant is pushing the, we can see that this fat over the sac at the neck, and then the transversalis fascia will be separated from this remaining sac, that is pseudo sac will be separated. We can see laterally there is a pulsation of the spermatic vessel and transmitted pulsation of the iliac vessel, that is pulsating. Now sac is almost separated, and below you can see this is the vast difference. So slowly now the entire sac is coming out, and we have to make a good pocket so that the mesh can be introduced, and it should cover the entire myopectoneal orifice, including vas deferens spermatic vessel and the inferior epigastric vessel. This is the spermatic vessel laterally, and medially there is a vas deferens, and the peritoneal flap is separated from both the structure. So almost the dissection of the right side is over. Now we will start the dissection of the left side. So again preperitoneal pocket is being performed on the left side. We can see again above is the inferior epigastric vessel, which is visible at 12 o'clock position. And this is the medial dissection, and again we have to medialize the bladder. So lateral and medial dissection should be performed first, before going to the sac dissection. That is important, because if you have not done a proper lateral and medial dissection and directly going to the sac is not good. In robotic, because we do not have a tactile feedback, so visual interpretation is very important, and we should be very careful that buttonhole should not be produced in the peritoneum. So, this is the inferomedial dissection and bladder is getting medialized, and again our aim is to reach up to the Cooper ligament and just enter into the space of radius. So, we can see here Cooper ligament is started visible, and this is the fat. We should always keep in mind that fat belongs to bladder. So, we should push the fat medially. And the fat in between two medial umbilical ligament was pushed down, because it is a bilateral hernia surgery. So, we can see from either side, from left you can see right also, and now there will be sac dissection. This side basically there is a very small or maybe invisible hernia, but we are doing prophylactic herniorrhaphy on mesh repair on this side as well. So, this is the spermatic vessel, and medially there is vast difference. Cooper ligament is already shining, we can see at around 1 o'clock position. So, this is the iliac vessel in between vas and spermatic vessel, which is pulsating. And there was very small sac of this side which has come out automatically. So, almost either side of dissection is over, and now we will do the mesh placement. One single mesh can be used, which can be brought from the right to left, and you can cut the mesh like a butterfly. But here one large mesh was not available, so we will use two mesh on the either side, and we will do the bilaterally, and we will do by suture. We will not use any tacker in this surgery. So, this is the spermatic vessel of the right side. And we can see in between two medial umbilical ligament there was no dissection. So, both the side of the medial umbilical ligament is visible, and bladder is in between the two medial umbilical ligament. So now we are waiting for the mesh to come, and assistant will introduce the mesh, and now the mesh has come and assistant has introduced the mesh, and we are using the simple polypropylene mesh on the either side. Two mesh is used, one single large mesh is also good. You can go anterior to the both medial umbilical ligament, and you can bring right to left like a bow tie or butterfly. So now the mesh of the left side has also been introduced, and we will place this mesh also on the left side of the pocket, preperitoneal pocket, which we have made. A suture with the needle is also introduced, and this is 2-0 vicryl, and we will fix the mesh by suturing, and then peritoneum also will be closed by suturing. So, in robotic surgery, these all things you have to wait for the assistant to do, and he has to introduce the needle, because as you know, robot itself cannot lift the mesh and introduce into the abdomen. So, this is the part which assistant has to do. So, mesh has to be nicely spreaded all over the structure. This is the inferomedial end of the mesh, which you can see it is over the Cooper ligament, and Cooper ligament is visible. In fact, either side of the Cooper ligament is visible from here, right as well as left. So, the mesh is nicely positioned, and it is covering the triangle of doom, triangle of pain, as well as trapezoid of disaster. So, fixation of the mesh is just started by suturing. Right side we have a needle holder with the mega needle holder with the scissors. So, the base of the needle holder has a scissors which can cut also. Suturing has advantage that it will be very easy in robotic surgery, and for the patient advantage is that there will be no pain. So, only 2 suture is enough. The purpose of suture is not to give the strength of the mesh. Purpose of this suture is just to give the position of the mesh so that it should not displace. So, now left side of mesh is also, we should be very careful that center of the mesh should be in the center of defect. Mesh should have 3 property, that adequate size, adequate memory and ultra light weight, and center of the mesh should must be in the center of defect. So, you can see the right side of the mesh and left side of the mesh both are touching each other. And both the mesh is together. So, that is why even a single large mesh is also good in these surgeries. Fixation of the mesh is done, and now we will do the suturing of the peritoneum, that is peritalization will be performed. Here it is barb suture which is used for closing the peritoneum, that is V lock. You can use the simple vicryl also. As we can see that suturing is very easy in the robotic surgery, and always in the peritoneum we should give continuous suturing. Initially loose suture should be kept loose for few bites and then it should be pulled. So, there is no need of termination in the barb suture. So, left side is done and now the right side of suturing will be performed. So, as we can see that there was no tacker used in this surgery, entire surgery was performed with the suturing, and the robotic has advantage because of the 3D vision. Suturing is very easy. So, now we cannot see any part of the mesh. One a small window is there on the medial aspect, that is buttonhole, that also you can suture. So, surgery is over, needle has to be carefully removed and all the instrument has to be removed and pneumoperitoneum has to be removed. So, thank you very much for watching this video. This was just a simple case of bilateral robotic transabdominal preperitoneal hernia repair. Thank you very much. Have a nice day.